Great, thank you so much, and thanks for the opportunity to be here. Talk a little bit about measuring and improving high-risk surgical care. So just two disclosures there. So I want to try to tackle three different goals briefly in less than 10 minutes. First is why focus on high-risk surgery. There's some real practical considerations why it's gotten so much attention. Two, talk about choosing the right measures. There's some real practical constraints about what we can measure and what makes sense when we're trying to improve quality of care for surgery. And then finally, we do have experience with centers of excellence and have a track record of what works and what doesn't. And so there are some unintended consequences we should be thinking about and thinking about ways to mitigate and prevent those. So this is kind of one of the landmark papers, now almost 2 decades old, from Dr. Birkmeyer, demonstrating that when we look at high-risk surgery, there's a lot of variation. These are rates of mortality across procedural volume for common high-risk procedures. You just see like tremendous 2, 3, 4-fold variation, drawing a lot of attention to these procedures. These surgeries cost a lot of money. So in one recent review of CMS spending, surgical episodes make up about half of the payments for Medicare spending. And when you put those together, a combination of high-risk cases and a lot of money, it's particularly noticeable for high-risk patients. So you see there the difference in episode payments for high-risk patients at low and high-quality hospital. You can start to get a picture. These are high-risk cases. It's costing a lot of money, and there's a lot of variability, which gathers a lot of interest. And what probably made it most exciting was this work almost about a decade ago by Dr. Ghaffuri that tried to examine why is there so much variation in mortality for these high-risk procedures. And he mapped out this sort of causal pathway of an operation occurs, there's a complication, it dominoes, and the patient dies. But what's interesting is that when you look at hospital variation, high and low mortality hospitals actually have the same rates of complications. But it's in fact their ability to rescue a patient after a complication that really stratifies the high and low mortality performers. So he termed that failure to rescue, building off some of the medical literature. It was really our ability to recognize and respond to complications. And sure enough, when we look at the improvements in mortality in the last decade for these high-risk procedures, about 2/3 of the improvement are attributable to our ability to rescue patients after a complication occurs. And notably, the rates of complications actually haven't really changed. It's really our ability to rescue. So taken together, we have expensive, high-risk cases that are highly variable, and there are these mechanisms that are potentially fixable or things that we can modify to make the cases more safe. So not surprisingly, a lot of people are interested. The Leapfrog group has created their volume pledge as a sort of a third-party group guiding people towards better care. CMS has created their alternative payment models, including surgical episodes, to try to find ways to drive down spending, recognizing these variation levers. And the public's gotten a lot of interest. So ProPublica made a lot of headlines a few years ago for trying to publicly report surgeons' surgical quality that had a lot of methodological flaws, but nonetheless, everyone's interested. So now that there's a lot of motivation and a lot of sort of universal interest, high-risk surgery, let's focus on it. There's ways to improve it. There's ways to save money. There's some really important methodologic constraints that I think we need to keep in mind that unfortunately often get overlooked. So Donna Bedian, this paper is now over 50 years old, and I'll just point out it's also about 50 pages, but has a lot of good stuff. And the core of it is he identifies sort of these 3 core ways that we evaluate quality, and they're all directly relevant to our conversation about COEs today, and I'll just kind of give you the highlights of each of them. So the first is structure, and this is probably the lowest hanging fruit, and it's the measurable attributes of hospital or providers. The most common one that we think about often in pancreatectomy is hospital volume. On the plus side, these are easy to measure and actually have pretty robust relationships for volume outcome relationships in these high-risk procedures, but it's pretty crude, and you can't really often change the structure of a hospital or readily change volumes that easily, so it's not perceived as too actionable. Next is process measures. I think the most common example that's now so universal is these preoperative checklists. If you're one of these task-based personalities who loves checkboxes, this is great because you find the one thing that wasn't checked and you have like an actionable lever to intervene on. But on the downside, for as much as we've gotten excited about checklists and processes of care, there's still very few processes of care that actually correlate with better outcomes. And even doing the processes of care don't always ensure the optimal outcome at the end. And then finally, outcomes. I think this, when you talk to surgeons, when you talk to patients, talk to health systems, this has the most face validity. It's like, look, don't micromanage what I did throughout the whole episode of care. Just evaluate me on the bottom line. If the patient did well, that's what really matters. And that's great. It has a lot of face validity, but it's really difficult to measure and has a lot of methodologic constraints in terms of volume and risk adjustment that really is not applicable to a lot of the procedures that we care a lot about. So just one example, this is another kind of what I call like the OG series of health services research and surgery. Most hospitals don't actually have enough volume to discriminate based on outcomes. So if you look at these high-risk procedures, that red line there shows you the hospital volume that would be needed to reliably discriminate high and low performers. Most hospitals don't meet that volume, and this was about 15 years ago. Now that mortality rates have collectively gone down, it's even harder to discriminate hospitals based on their volume. So how do you start to make sense of these constraints? There's some methodologic constraints, and how do you align those with the characteristics of procedures? The best way to think about it is in terms of both the procedural volume and the procedural risk. So I'll just focus on the top two because we're talking about high-risk surgery. We would love to have high-risk procedures that are performed in high volume, like colectomy, because you have occurrences that are frequent, but also the procedure is common, so you can start to reliably distinguish different outcomes. But for like esophagectomy and pancreatectomy, where the volume just isn't there at individual hospitals, we rely on structure, just saying that you have enough adequate volume per year, did you have the right resources in place as sort of our best surrogate measure of quality. So keeping those both in mind, COEs are certainly not a new concept. There have been a lot of efforts to create centers of excellence, primarily in bariatrics. And I think they give us some cautionary tales and some lesson learned that really inform our discussion for the rest of this session about how to be thoughtful about creating and implementing a COE. So this is work looking at bariatric centers of excellence, and I'll just draw your attention to a couple different things. During this time period, this was actually when laparoscopic surgery was being widely adopted in bariatric surgery, and you see that before Medicare decided to restrict payment to centers of excellence, quality of care had actually already been improving. And so if you just compared before and after, you may misleadingly think that the designation created a large difference, but actually the trend was in place long before the designation happened. Furthermore, when you start comparing it to non-Medicare patients or people not exposed to this center of excellence restriction, the difference between the two is almost a wash, and you realize that the center of excellence designation actually didn't impact the quality of care, and that was already improving on its own anyway. But that aside, even if you said, well, everyone's getting better, so that's okay, COE designation, especially with payment restrictions, has unintended consequences. So this is the percentage of non-white beneficiaries, patients who underwent bariatric procedures, and after the COE payment restriction, you see a significant drop in the number of Medicare beneficiaries, creating real identifiable access issues. Next, even if you go to a COE, so in the case of bariatrics, essentially almost every bariatric center became a center of excellence. There was wide variation. So even though you have a number of centers who are checking all the boxes, doing all the processes of care, when you look at their outcomes, there's still enormous variation. And even when you look at something like volume, which is sort of our like tried and true that we really like to hang our hat on, the variation reproduces itself across all three levels of volume for these cases. So the COE designation alone doesn't quite do it. And then quickly, in a minute, I'll show you one other concern. This is the Hospital Readmission Reductions Program, not a COE, but just another large-scale quality improvement initiative that was really hailed as probably one of the best quality improvement incentives kind of in our era. But when you look a little closer, you might get a little suspicious. How is it that all the quality improvement happened in almost a single quarter? Like, what happened at the beginning of 2011 where all the hospitals magically improved their readmission rates? Well, it turns out that's the same year that Medicare allowed coded comorbidities to move from 10 to 25 diagnoses. So what did every hospital do? exactly what every consultant told them to do, accurately code the severity of illness for all your patients. And so when you put that together and evaluate the coded severity of patients and the drop in readmissions, we basically identified that 2/3 of the reduction in readmissions was actually just due to coded severity and not actually changes in quality. I only point that out to say that that was off the radar of most people, and our group included celebrated that hospital readmission reductions program as this huge quality improvement, but overlooked that actually the way we were measuring quality had changed significantly right in the middle of that intervention period. So I'm a little out of time, so I'll just say high-risk surgery certainly has our attention. We need to think really thoughtfully about what the right measures are, and take some lessons learned from previous COE attempts to make sure we avoid unintended consequences. Go blue, and thank you.